Now, in the third section of our lecture about subacute meningitis, we will discuss some treatment options for the treatment of subacute meningitis. And in this, we will talk empirical therapy, antimicrobial therapy, and antifungals. So far, we talked about the two causes of subacute meningitis, and in this, we talked in detail about Mycobacterium tuberculosis meningitis, and also we talked about the fungal meningitis. So, we will discuss the treatment options available for these conditions. So the treatment is empirical therapy of tuberculous meningitis on the basis of high suspicion index. Initial therapy is isoniazid. These are all the same anti-tuberculin drugs used for tuberculosis or used for pulmonary tuberculosis. They are also used for tuberculous meningitis. And remember, these anti-tuberculin drugs are very, very effective now. Patient needs to complete the recommended course of these anti-tuberculin drugs. And in the before the advent of these anti-tuberculin drugs, there were lot of deaths from the tuberculosis, and it was one of the disease which is associated with very high mortality rate. But after the advent of these anti-tuberculin drugs, the mortality rate decreases considerably, and there was very low number of tuberculin cases. But now again, the tuberculosis again is on rise as a result of increasing infections like HIV, in which the patient's immune system is very, very badly affected. So now again it's on rise, and patients should be very carefully monitored and followed. So isoniazid, INH, very, very effective drug for the tuberculosis. Isoniazid, then we have rifampicin, pyrazinamide, ethambutol, pyridoxine, and then another antimicrobial sensitivity, ethambutol discontinued. So ethambutol is discontinued. Good clinical response, pyrazinamide discontinued. Dexamethasone therapy for HIV negative patients with tuberculous meningitis. So as I mentioned, it's at rise because of the infections like HIV. So if the patient has meningitis, tuberculous meningitis without HIV infection, we can use dexamethasone. So antimicrobial, if there is a sensitivity, then we should discontinue ethambutol. Once there is good clinical response, then we should discontinue pyrazinamide. Meningitis due to coccidioides neoformans, induction therapy is by amphotericin B and flucytosine. These are antifungal drugs, and there is induction therapy is with the amphotericin B and flucytosine for at least 4 weeks, followed by consolidation therapy. So we have induction therapy followed by consolidation therapy. Induction therapy should be given for 4 weeks. Fungal infections are usually resistant to the treatment, so keep in mind, so they are not very easily treatable infections. Organ transplant recipient, people who have organ transplantation and they develop fungal meningitis, then they are treated with liposomal amphotericin B, treated with amphotericin B lipid complex, plus flu cytosine. So that's the difference if it's a normal person, if it's with the transplant patient, transplant recipient patient, then we should have liposomal amphotericin B and lipid complex. CSF yeast cultures are performed for sterilization, and then 8 to 10 weeks course of fluconazole is performed. So culture is done for looking for sterilization, and then we should treat the patient after the culture with 8 to 10 weeks of fluconazole therapy. CSF culture is sterile, then fluconazole dose decrease. So we should do the culture for sterilization. If it is not sterile, then we should give the treatment for 8 to 10 weeks. If it's sterile, then we should decrease the dose and the time. Patients with HIV infection given amphotericin B or lipid formulation and flucytosine. So again, if patient with HIV, because they have decreased immunity, they have decreased or impaired immune system, like same with the patient like who are transplant recipient, they should get the treatment as the transplant recipient, including lipid formulation of amphotericin B. Next, meningitis due to histoplasma capsulatum. How we treat that? It's again treated with amphotericin B for 4 to 12 weeks. Total dose of 30 milligram per kilogram body weight. So this is by the body weight. Fungal cultures, sterile therapy discontinue. So if the culture comes sterile, then we should discontinue the therapy. Otherwise, it's amphotericin B for about 4 to 12 weeks. So main therapy you notice is amphotericin B or flucytosine, and then we have it's a long treatment, about 10 to 12 weeks of treatment. Once the cultures comes up sterile, then we should discontinue the therapy. Maintenance therapy is with itraconazole 2 to 3 times daily. The coccidioides immitis meningitis is treated by high dose of fluconazole as monotherapy. So fluconazole is used in C. immitis meningitis as a monotherapy, as the only drug that is used. Intravenous or intrathecal amphotericin B. Lifelong therapy with fluconazole to prevent relapse. So we can use the lifelong therapy to prevent the relapse of coccidiomycosis, and this is lifetime treatment with fluconazole that is used as a monotherapy. Those with renal dysfunction and have C. immitis meningitis, ambison or amphotericin B lipid complex is used in those patients. Sterile fungal cultures, when we should use ventriculostomy is used. So that was all about different treatment options available for the subacute meningitis caused by the Mycobacterium tuberculosis, and also by different fungi that can cause meningitis. So thank you for watching sqadia.com.